Good afternoon. Today we are talking about a case of anaphylaxis.
Okay.
Right now, we received a patient complaining of itching, and after ingestion of prawns, 30 minutes after ingestion of prawns.
Okay.
On arrival with the initial 10-second assessment, patient was conscious, oriented, and obeying commands, and she had difficulty in speaking one full sentence. Then we connected the patient to the leads, and then we started our initial primary survey. In the initial primary survey, airway wise, the patient had hoarseness of voice present, and there was no stridor or pooling of secretion or fallen tongue.
Okay.
And in breathing, patient had respirator of 22 per minute, and saturation was 95% in room air. Chest movements were bilaterally symmetrical, but bilateral V's was present and air entry was equal, sir. V's was present.
Okay.
Then circulation wise, heart rate was 100 per minute, blood pressure 130 by 74 mm of Hg. All peripheral pulses were felt, CRT less than 2 seconds, and no active bleeding. At this place, we put 2 large IV bore cannulas, sir. And next, disability wise, GCS was E4, V5, M6. Pupils were bilaterally 2.5 mm and reactive to light. GRBS was 137.
Okay.
Exposure wise, she was febrile, hypothermia, and hypothermia was prevented by giving a blanket. Now, as per the resuscitation protocol of the anaphylaxis, first we had identified
before that, so initially you told the patient had some breathing difficulty. That's all, no?
Yes, sir. She had breathing difficulties, sir.
Okay. That no other symptoms.
No other symptoms. Saturation was 95% and wheeze was present, sir.
Okay. Okay. And some hoarseness of voice.
Hoarseness of voice. There was
Any other
hoarseness of
negative
voice.
history you want to tell at this point?
Still, we didn't take the history.
But still,
Yeah, negative history wise, there was no stridor
Ah.
and there was no hypotension as of now.
Yeah, and any skin changes?
Skin changes, there were rashes present all over the body, sir. Itching was present for the patient.
Okay. Okay. Fine.
So, as per the resuscitation protocol, we first went to the ABCDE. Then, coming to the diagnosis, the diagnostic criteria for anaphylaxis, as of now, diagnostic criteria wise, sir. The first, there are 2 criteria. In the first criteria, the
This is the latest one.
Latest
Right?
criteria.
This is from the World Allergic Organization. Okay.
World Allergy Organization. 2021 update of that. In the first criteria, there's a involvement of the skin mucosal tissue. Along with that, at least one of the following, in which one A, respiratory compromise,
Okay.
B, circulation compromise such as the hypotension, and C, any other gastrointestinal complaints or any other vomiting and etc.
Okay.
In the second criteria, even without the involvement of the skin changes or the mucosal changes, having the respective ABC, like having any respiratory compromise such as stridor or dyspnea, or circulatory like hypotension or the gastrointestinal. This is the criteria for the anaphylaxis.
So basically, hypotension, bronchospasm, or laryngeal involvement.
Laryngeal
Okay. Even
involvement.
without the
Itching, skin involvement.
Okay.
Skin involvement.
But with a history of
History of the exposure of the allergen.
okay.
Now, coming to the secondary survey, coming to the sample history of the patient, we get to know
at that point you have to intervene or not?
You have to intervene, sir. Right now, the patient is having wheeze, and that is showing there is a airway compromise. So right now we intervene.
I wouldn't say airway is compromised at this point. There are some respiratory symptoms.
Respiratory symptoms. So right now we call for help and raise the patients like as per the algorithm, and then we start with the adrenaline. The adrenaline dosage would be 0.5 ml of 1:1000 concentration, giving in IM.
Continue.
So like
You can continue.
yeah.
Then
There's
so where do you give IM?
IM we had given in anterolateral aspect of the thigh. We can give in deltoid also.
Okay. Usually the outer aspect of
Outer aspect of the thigh is
0.3 to 0.7 is the dose. Okay.
And
of 1 mg per ml dose. Okay.
1 mg per ml. We regularly assess every 5 minutes to check if the symptoms reappear or did they subside. After giving the first dose of the adrenaline, after 5 minutes assessment, the patient had relieved of her wheeze, of her breathing difficulty, and itching also has subsided.
For our patient.
For
Suppose
our
if it is not improving, then how
it
many
is not
times
improving, we get for 2 cycles of 2 times we give the adrenaline.
So 5 minutes after you repeat the next dose, even if it is not improving,
then we follow the algorithm of the refractory anaphylactic
Okay.
algorithm, in which they start with IV titration of the adrenaline, continuous IV infusion of the adrenaline.
What's the dose?
1:10,000 with
Infusion rate is
in
0.1 mg per kg per hour.
0.1 mg per kg per hour.
Yeah.
After this
No, along with that, what are the treatment? Only adrenaline you want to give or anything else? At this
treatment has actually 3 stages, sir. First phase would be the epinephrine, the adrenaline, and second would be the oxygen if the patient is in distress right now, as is now, and third would be the IV fluid if the patient is hypotension.
Okay.
Bolus
We'll come
of
to that in
fluid.
detail. You can continue with the sample history. Yeah.
The sample history, sir. The sample history, this patient was having the signs and symptoms. Patient developed acute onset itching all over the body, and there was swelling of the face and neck with voice change and difficulty in breathing after consuming prawns 30 minutes ago, sir. And the patient has no allergy medications, nil, sir. Patient is not on any other medication. There is no past and surgical history, and the last meal was 30 minutes
So
ago.
this patient does not have any past history of any allergies.
No, sir.
Prawn she has taken before.
First time. She has taken,
for the first time. Okay. So previously, what is the age of the patient by the way?
The age of the patient was 26-year-old patient, sir.
Okay. No other past history of allergy to anything?
No
Not
other.
taken prawns before, first time taken.
First time took the prawns history. Prawns, after ingestion of the prawns, after 30 minutes, she has visited our ED with the complaints of itching and voice change, hoarseness, sir.
Okay.
So after giving the adrenaline dose, after a 5 minutes assessment, patient had improved her symptoms, and there were right now no other symptoms, sir. Apart from the treatment wise, regarding the treatment wise, we start with the adrenaline, and depending on the patient's symptoms, if it's requiring oxygen, we could connect her to the oxygen to maintain it above 95%. And the third would be giving IV fluids bolus if there is a hypotension. 1 liter of IV fluid NS can be given bolus. And the secondary line of treatment to prevent the recurrence of the symptoms would be giving an antihistaminic treatment, like we had given Rantax or injection Rantax 50 mg we had given, sir. And the other thing would be giving corticosteroids. We had given
both H1 and H2 has a role, right?
H1 and H2, yes. Corticosteroids can be given. Corticosteroids we had given hydrocortisone 100 mg, sir. Apart from that, depending upon the symptom, like as she was having wheeze, suspecting a bronchospasm kind of thing, we had given her nebulization with Duolin of 3 seconds.
All you need is salbutamol.
Salbutamol, sir. That is the line of the treatment.
If you are not having salbutamol,
ipratropium.
No, I mean, if the alternative for nebulizations will be metered-dose inhalers.
Yes, sir.
Okay, you can ask them to take 2 to 3 puffs of MDI of beta-2.
Yes, after such, she was relieved of her wheeze, and she was not having any breathing difficulty, and the itching was also stopped. So apart from that, the patient has to be observed for 1 day to see if there is any recurrence of the symptoms. So we have the discharge, regarding the planning of the discharge of the patient with anaphylaxis. First, we need to educate the patient, as the first time she is not aware of such thing. We need to educate that this is an allergic kind of a reaction, and next time she should be aware that she should not be having ingredients of the food which is consisting of the prawn. Apart from that, we need to educate her the epinephrine auto-injector, and next time if she is having such a dose of breathlessness, she should inject herself.
You don't have it freely available in our country, no?
Yes.
So, yeah.
And for her discharge medication was antihistaminics can be prescribed, and corticosteroids for the next 2 to 3 days. And regarding the prevention details, that should for the further exposure, to prevent the further exposure.
Okay. So suppose the main thing to be discussed in this scenario will be an airway management, right?
Yes.
So luckily for us, this patient did not have any much of airway compromise.
Yes.
She responded to the dose of epinephrine. Okay. Now, when are you going to consider intubating a patient with severe anaphylaxis?
When we assess that there is a severe airway compromise, not maintaining saturation, we can be sure that there is a glottic edema of the glottis, so then we can plan for intubation.
Because any patient with stridor in anaphylaxis always keep things ready for
it.
Any symptoms of swollen tongue. So that's a scenario where you are anticipating that the patient is going to
difficult.
is going to end up
Airways
with
will
a with an difficult airway. So you are justified in going ahead with an preemptive airway, that is endotracheal intubation upfront, if the patient is not responding to your initial line of management and symptoms are worsening. Okay. Suppose it's a cannot intubate kind of scenario. What will be the next thing?
LMA would be preferred.
You cannot open the mouth. No, this patient.
Okay.
Tongues are all swollen up. Definitely, you need to go for something called as
Emergency cricotheracy.
needle. Okay, cricothyroidotomy. So, do you know anything about cricothyroidotomy? Like, okay, fine. So, few things you need to remember is that there are different types in which methods in which you can do the cricothyroidotomy. What we usually prefer to do here is a needle cricothyroidotomy. That is like we are Seldinger technique only. Okay, basically you identify the anatomical landmarks, you palpate your cricothyroid membrane, and usually using a needle. You have a separate cricothyrotomy set. Okay, so first step will be to take the needle, and with your typical your Seldinger technique only, from the head end we will go for a 45 degrees. You can draw here.
Yes.
So suppose if it is the neck and the head is here,
Yes.
You enter like this at 45 degrees. Okay. So the needle is in. You aspirate and make sure that the needle end is here. After that, you introduce the guide wire. Okay. And then you remove the introduce the needle with the dilator. There are sets which comes in with the dilator itself and the cricothyrotomy tube. So with both things, you insert it after dilatation of the skin and you put it in. This is the usual Seldinger method you can do. There are to be very frank, there are more than one method. Other thing will be your scalpel finger bougie method. There you go with that scalpel itself and put an incision. With the finger you dissect and put in a bougie. You are intubating bougie. Then through the bougie you will put the tube. Okay. And then at the end of it, if you are using a proper tube, you can connect it directly to the ambu bag or ventilator. If you are using other small size of tubes, there are a lot of jugaad methods in which you can connect the O2 to it. Okay. You can use a smaller ET tube catheter, put it there. Even with a syringe thing, no? Syringe you can cut it and use it as an kind of an adapter kind of thing for ambuing and all. So that is one thing. Okay. So needle cricothyrotomy, basically you should have some idea about how to do it, and also the basic things which are needed for that. Okay. So that will be the quick airway kind of management, right? Anything else with anaphylaxis? Okay. Steroids you told, antihistamines you told. Other thing will be once you're discharging the patient, ideally you should ask the patient to get in an proper allergic consult. Okay, because these episodes can recur, so they'll need a proper evaluation in terms of what is the trigger. Is the patient going to trigger with